Hello, good morning. It's recording. Okay. Today I'll be taking the same class like primary open angle glaucoma, the continuation of the same class. Okay. If you have any difficulty, you can message me. Okay. Okay. Or our HOD, you can contact our HOD also. Okay. Fine. I'll be just continuing my class. Today's class. Is it more? So this was explained in the last class already, how the arrangement of the nerve fibers are there in the retina. Okay, around this is the disc. Around the disc, how the nerve fibers comes. Okay, superiorly superior arcuate fibers, inferiorly inferior arcuate fibers, then superior radiating fibers from the nasal side, inferior radiating fibers from the infranasal side, and the papillomacular bundle, which is arranged straight from macula to the disc. Okay, this is the last fibers which are going to affect in glaucoma. And then from the periphery, the nerve fibers are arranged in the periphery of the disc. The nerve fibers which are arising from the periphery of the retina will be there in the periphery of the disc. So visual field defects, some names are given for these visual field defects. The field defects usually run parallel to the changes of the optic nerve head. Okay. So wherever there is a nerve fiber layer defect, that part is depicted as there is visual field defects. Okay. So the names are like isopter contraction, bearing of blind spot, small wing-shaped paracentral scotoma. Each one I'll be discussing later, okay? Just to enumerate, I have put it in one slide. Cedal scotoma, arcuate or germ scotoma, ring or double arcuate scotoma, Roney's central nasal step, and then the last one is tubular vision. Each one I'll be dealing now. So this may be asked as a 5 marks question or a part of main question. Okay. So the visual field defect is one of the criteria for defining a glaucoma. So this is very, very important. Initially, whatever we observe is in Jerum's area. The Jerum's area is 10 to 25 degree from the fixation. The fixation is from the fovea. Fovea is the fixating point. Okay. So around the fovea, 10 to 25 degree around it is called as Jerum's area. So what happens in isopter contraction? This here it referred to mild generalized constriction of central as well as peripheral field. It is not a pathognomic of glaucoma. It can occur even in other conditions, but initially in glaucoma there may be isopter contraction. These diagrams have to be drawn like that. Okay, if this is the blind spot and then this is the fixation point. Okay, that's what I was telling. 10 to 20 degree around the fixation point is called as Jerum's area. So whatever visual field defects we see in this area of the fixation point, we consider it as important for glaucoma. Okay, so next moving on to what is Cedal scotoma. So just paracentral scotoma, okay, paracentral small, sorry, this directly I moved to Cedal scotoma. Before that, if this is there is a blind spot because of the optic disc. Okay, next to that blind spot, one small spot appears, that is the scotoma appears, that is called as paracentral scotoma. Okay, so after that paracentral scotoma, if this paracentral scotoma joins with this blind spot, paracentral scotoma joins with the blind spot, it forms a cecal shaped scotoma. Okay, scotoma means a non-seeing area. I think you already know about it. In physiology you would have learned. Okay, scotoma means a non-seeing area. So there will be a cecal shaped scotoma here. This is the one of the visual field defects, that is called as Cedal scotoma. Then if this scotoma increases in size and then extension of the sedal scotoma in an area either above or below. It may be below like this or above. In the arcuate manner, it is called as arcuate scotoma. Superiorly, if it is there, means that is called as superior arcuate scotoma, and if it is inferior, then if it is inferior arcuate scotoma, and it doesn't cross the horizontal midline. That is the pathognomic of uh, glaucoma field defects. Sorry, my slides are not changing that fast. Bear with us. Sorry, one or two slides are missing. So this arcuate scotoma, if it is inferiorly, if it is present, then it is called as inferior arcuate scotoma. And if the whole thing, if it is formed like superior arcuate scotoma, and inferiorly, if inferior arcuate scotoma is there, they join together form a tubular vision. Only in the center there will be vision, and the periphery there will be absence of the so scotoma extend. That is called as double arcuate scotoma. Okay, and then when they are joined, there may be a small step-like thing on the nasal side. So that is called as Ronne's ring. The ocular association, like along with POAG, that is primary open angle glaucoma, maybe usually it is with high myopia. High myopes are more prone for primary open angle glaucoma, and even with retinitis pigmentosa patients are also more prone for primary open angle glaucoma. So other than visual field effects, till now what we studied is disc changes. We have examined the patient clinically, then followed by we have done a visual IOP checking and then visual field. So other investigations then, first and foremost, it is very important thing what we have to do is tonometry. Tonometry is to measure the normal intraocular pressure. Okay. So in that tonometry, we have to, if we are suspecting primary open angle glaucoma, we have to look for diurnal variation test and then provocative tests. Okay, if we have a borderline cases, if the patient is having 20 millimeters of mercury, so that is neither normal, like high normal. It comes under high normal. Or, so in those cases, in borderline cases, to prove that it is POAG, we do a provocative test that will be explained. Okay. Then we do a central corneal thickness measurement using pachymetry. Okay. Central corneal thickness, because we get high false reading or low reading depending upon the thickness of the cornea. If the cornea is thin, we falsely record the IOP as low. So that's why we need to check the central corneal thickness. Then gonioscopy has to be done to rule out whether primary open angle or it is angle closure glaucoma. And then perimetry to detect the visual field defects. And whatever optic disc changes we have noticed, we have to document with that using color pencils. That is also very important for a follow-up patient. Okay, documentation of optic disc changes. And then finally, or a newer one, that is nerve fiber layer analysis. Like OCT, all this, or HRA, all are available to measure the nerve fiber layer. This is just a pictorial depiction, a picture showing measuring the intraocular pressure using Goldmann sublimation tonometer. Okay. Gonioscopy being done. It's a 4-mirror gonioscope. Okay, all the 4 angles can be visualized at the same time. Then ophthalmoscopy to assess the disc changes. It can be direct ophthalmoscope. This is a picture of direct ophthalmoscope. Using a direct ophthalmoscope, or indirect ophthalmoscope, we can, or using a 90D lens in the slit lamp, we can do a disc evaluation and then record it. This is the picture showing like visual field defects and be measured using a perimetry. In perimeter, there may be static perimeter and then kinetic perimeter. This is a automated perimeter, that is kinetic perimeter. Other way is crude way. If it is in last stages of glaucoma, okay, in that even confrontation test, clinically we can do a confrontation test to detect visual field defects. This is a newer diagnostic modality. Using confocal scanning, we can measure the retinal nerve fiber layer. So I told you intraocular pressure is a very important thing what we have to measure. Okay. So what we do is normal diurnal variation will be there otherwise also in a normal person. But in glaucoma, if the variation is more than 5 millimeters of mercury using the Shiots, then we call it as a suspicious. Variation means morning and afternoon or evening variations we'll see. Okay. If it is over 5 millimeters of mercury, then we call it as a suspicious, and the variation if it is more than 8 millimeters of mercury, then it is a diagnostic of glaucoma. And then one more provocative test, that is water drinking test for open angle glaucoma. So we take a baseline intraocular pressure, either using a applanation tonometer or Shiots tonometer, whatever it is. Baseline intraocular pressure has to be tested, and then after 8 hours of fasting, then what we do is we ask the patient to drink 1 liter of water, and then every 15 minutes for an hour we check the intraocular pressure. So for about 4 times we measure intraocular pressure in that patient, and a rise of 8 millimeters of mercury or more is said to be diagnostic of primary open angle glaucoma. But nowadays in our clinics we don't do all this. We directly like earlier than this we can pick up using OCT, that is optical coherence tomography. If any nerve fiber layer defect is there, then we can pick up glaucoma even in the early stages. So we do that, but still for theory purpose you should know this. Okay. So after this baseline evaluation, we have to grade according to the severity of the glaucoma depending upon the optic disc changes, visual field defects and the intraocular pressure. We grade the glaucoma into mild, moderate and severe glaucoma. Okay. So in mild glaucoma, the characteristic optic nerve abnormalities are consistent with glaucoma but with normal visual field in mild one. In moderate, what happens? Visual field abnormalities will be there. In severe, advanced visual field abnormalities can be seen, like a tubular vision. Okay. So what do we have in our armamentarium to treat them? That is, the therapeutic choices include medical therapy. First and foremost, it is a medical therapy what we have to try, and then laser therapy, and then finally, if not, then surgical line of management. That is filtration surgery, that is trabeculectomy. So first and foremost, we have to treat them with medical therapy. In all the patients, we do try with the medical therapy. The basic principle of this medical therapy of primary open angle glaucoma are, first, we have to identify the target pressure. So to know what is this target pressure, okay, I'll be telling it in the next few slides. Okay, first we have to set a target. How much is, because that is the only, IOP is the only one variable which we can modify. Okay, so we have to set a target pressure for that patient, and to achieve that target pressure, either a single drug or like a single drug therapy is used. If that target pressure cannot be attained by us using a single drug, then we go for a combination of drugs. So combination of two or more drugs. So three is the maximum drug. Like three drugs can be used maximally. So that can be used as a combination therapy. And after that, monitoring of the therapy by disc changes, visual field, and tonometry is most essential on a regular follow-up. Whether after achieving that target pressure, the disease process is going to, because all these glaucoma changes, whatever I have told, is a irreversible change. So we can't reverse back the changes which has already occurred. Only thing what we can do is prevent the further progression of these disease. So that is our motto. So I was talking about the target pressure. So what is this target pressure? It is an IOP level identified for each individual. Okay, so it is customized, identified for each individual, below which the further damage is unlikely. Okay, if already glaucoma damage has occurred, so with this pressure we set one pressure. With that pressure, there is no further damage. That is, progression of disease cannot occur with this pressure. So this is assessed by severity existing, we have to assess clinically the optic disc changes, the rapidity of damage, the general health of the patient, and even the age of the patient is also considered to set a target pressure. And if we find if it is a mild glaucoma, then we set a target pressure of less than 18 millimeters. That is a rough, okay, it is not fixed like it should be like this, but it should be roughly below 18 millimeters of mercury. That is around 20% less than the IOP what that patient had in during the presentation. In moderate glaucoma, it is 30% less than what was the initial IOP the patient had. So it comes around less than 16 millimeters of mercury. And in the severe form of glaucoma, we usually tend to set the IOP at the lower range, that is 45% lesser than the what initial IOP what patient was having. That is less than 14 millimeters of mercury will be the target pressure which is set for that patient. Then monitoring of optic nerve and visual field and preserve the remaining visual acuity is our goal. So what are the medical drugs which we use? The first and foremost, the first line of drug what we use is the prostaglandin analogs. Okay, this itself, that medical management of glaucoma itself is a question. Okay, and then even in Viva, we give these drugs and then tell you people to identify and tell the side effects and then uses. So pay attention and read more this one, anti-glaucoma medication. Prostaglandin analogs, then comes beta blockers, parasympathomimetic drugs, then comes the sympathomimetic drugs, carbonic anhydrase inhibitors, and hyperosmotic drugs. Newer one is neuroprotectors, because neuroprotectors are used because in the pathogenesis of glaucoma we have already studied it is the ganglion cell death. So the nerve protection is more important. So neuroprotectors have been proposed now. So broadly, the anti-glaucoma medication can be classified into we know the pathogenesis of glaucoma, no? So according to that, so which increases the aqueous outflow, the drugs which increases the aqueous outflow, and the drugs which decreases the aqueous production. Okay, so IOP will be more only when there is increased aqueous production or the outflow is hampered anywhere. Okay, if there is obstruction to the outflow. So if we overcome by these drugs, then that will be the treatment. Okay, so to increase the aqueous outflow, the drugs which we used is pilocarpine alpha agonists. Okay, And then uveoscleral outflow is increased using prostaglandin analogs. Okay. To decrease the aqueous production, the drugs whatever we use is are beta blockers, carbonic anhydrase inhibitors, and then alpha agonists. So, coming to prostaglandin analogs. This is, as I already mentioned, it is a first line anti-glaucoma drug. Here, there is how it acts is like it increases the aqueous outflow by increasing the uveoscleral outflow. While explaining the physiology, I have already explained you how aqueous humor drains. Okay, so 80% is by how only 20% is by uveoscleral outflow, other 80% is by conventional flow. So this acts on this 20% that is uveoscleral outflow. This prostaglandin analogs increases the uveoscleral outflow. So for example, latanoprost, that is 0.005% once daily at night can be used. Okay. So this is usually used for primary open angle glaucoma, prostaglandin analog, and then this is very effective for glaucoma. Other than latanoprost, travoprost, that is 0.004% travoprost, bimatoprost, all this can be used. The only drawback of this is it is little expensive for the patient, but very good thing is it is only the dosage is only once at night time application. Okay, one drop at a night is enough. So the contraindication for this prostaglandin analogs are the inflammatory glaucomas we usually don't prescribe, but here it is for primary open angle glaucoma, this is the drug of choice. So if anybody asks which is the drug of choice for primary open angle glaucoma, it will be a prostaglandin analog, that is latanoprost, travoprost or bimatoprost. But this also has few side effects. The side effects will be like iris pigmentation will be there, and then the lashes will grow more. So that is called as hypertrichomy. Then hypertrichosis, and then conjunctival hyperemia may be there. These are the few minimal side effects which will be developed because of prostaglandin analogs. Then comes the beta blocker. Actually, this is most commonly used drug is beta blocker. This is because of the as I told you, prostaglandin analogs are expensive. So to overcome that, like in poor people also can afford this beta blockers. So this is used most commonly in a country like us. Okay. So the mechanism of action is this acts by decreasing aqueous production. Okay, thereby reducing the intraocular pressure. The common drugs which are used, the beta blockers are timolol, betoxolol. Timolol 0.25% or 0.5. Most commonly it is 4.5% is what is used. Okay, betoxolol, levobinolol, cartilol. Okay, so the commonest one what we use is timolol. But this is a non-selective beta blocker, and then it is usually used in a BD dosage. That is morning 1 drop and evening 1 drop is usually what we prescribe for glaucoma. But the beta blocker is used for all types of glaucoma. But it is very important to ask the history before prescribing the beta blockers. The history of asthma and then any cardiac problem has to be asked, because in asthmatics, because it is a non-selective beta blocker, there may be contraction of the bronchospasm can occur and precipitate asthma, and then bradycardia, it can induce bradycardia. So that's why we have to ask asthma history or cardiac history before prescribing beta blockers. So in that cases, timolol is, if we have this history, timolol is avoided, contraindicated, and then we prescribe a betoxolol, which is a selective beta blocker. So betoxolol is safe in asthmatic. So we can use betoxolol instead of timolol. Okay. Coming to parasympathomimetic drug, that is miotics. It has a major role in primary angle closure glaucoma. Pilocarpine, I have already told. Miotics. It is a drug of choice in ACG, but still it can be used in POAG also. Okay, and then, but most of them, like nowadays, we don't use this pilocarpine because of its side effects, like spasm of accommodation, frontal headache. Sometimes it is very rarely. RD can also occur with pilocarpine. Okay, but still it is there in our list. Then comes the sympathomimetic drugs, that is alpha agonists. This has a dual action, that is aqueous, it increases the aqueous outflow also, and then it decreases the aqueous production also. But the IOP reduction rate is not that much compared to prostaglandin analogs and then beta blockers. That's why it is not used as a first line of drug, but still it has a, like few drugs has a neuroprotective action also. So it is a better drug for a combination therapy. Apraclonidine 0.5% or brimonidine 0.2% BD is the dosage. So as I told, IOP reduction is not that much. So in milder cases, we can use, or in a moderate to severe glaucoma as a combination therapy, this can be used. The side effect being the allergic conjunctivitis like picture we can have with this alpha adrenergic drugs. The other group is carbonic anhydrase inhibitors, which is most commonly systemically used, not a topical medication. Like topically also it is available, but systemically we use this more. The topical preparation is dorzolamide 2%, which is like for TID dosage. Then orally, that is systemically, 250 milligrams of mercury, sorry, not mercury, 250 milligram tablets are available. So in very high pressure, we can even give 500 milligrams at a time. Okay, so 2 tablets at a time can be given in initial, but this systemic drug cannot be given for more than 3 days. Okay. So for initial control along with topical medication, we can use this drug as like systemic drug, which reduces the aqueous production. But this drug cannot be used for a long-term therapy. But in a glaucoma, it is a lifelong treatment. So this is only in acute phases we can use this carbonic anhydrase inhibitors. So some additive therapy. The side effects what we see because of carbonic anhydrase inhibitors, that is oral, after prescribing oral tablets, we usually tell the patients to have tender coconut and have banana because this causes hypokalemia. So to combat that, we usually prescribe banana, which is rich in potassium, and then there may be complaints of paresthesis, abdominal discomfort, diarrhea, renal calculi. All these are side effects because of long-term use of this drug. Then in acute cases, hyperosmotic drugs can also be used. This is a systemic anti-glaucoma drug. The osmotic pressure gradient, it draws the water from the vitreous. That's how it reduces the intraocular pressure. The main one what we use is mannitol, okay? Or I think this is already discussed during angle closure glaucoma. I was telling about this. No, it has a major role in angle closure glaucoma because in acute attack, this is the only drug which reduces the intraocular pressure in acute attack, like high pressure. Mannitol. Then glycerol can be used. Isosorbide, urea. These are less commonly used. Mannitol is more commonly used, and glycerol In diabetic patients, we can't use this cholesterol. So in emergency IOP lowering agent, mannitol 20% is the common drug which is used, and 1 to 2 milligram per kg body weight is the drug. Like mannitol is the safe drug in diabetics, not the cholesterol. And just to mention the neuroprotectors, the glutamate inhibitors, calcium channel blockers used, nitric oxide synthase inhibitors, and even the gene therapy has been tried, but not much of success for this gene therapy. Till now, what we studied is all the medical line of management is, I have covered till medical line of management. Moving on to laser therapy. So the trabeculoplasty, the outflow can be increased, or the aqueous outflow can be increased using a laser therapy also. But this has not gained much of popularity for glaucoma treatment. But still, this can be tried. This can be tried in mild to moderate glaucoma, not in severe glaucoma. And then where the trabecular meshwork are deeply pigmented, this has a better role. Okay, the argon laser or diode laser is used. So it is called as ALT, argon laser trabeculoplasty, if we use argon laser, or selective laser trabeculoplasty, SLT, also can be used. It is used in open angle glaucoma. So the IOP, the indications are IOP is uncontrolled despite maximal tolerated medical therapy, and sometimes even as a primary therapy when there is non-compliance for medical therapy. But definitely it does not replace the medical therapy at all. But it was tried before. But nowadays, not many people prefer this. But for your answer completion sake, you need to write this laser therapy also. Okay. The laser spots are applied to gonioscopically to coagulate the trabecular meshwork. See, these are the laser burn marks. This is the trabecular meshwork where there is laser burn marks to open the trabecular meshwork. The collapsed trabecular beams becomes taut, increases the space available for aqueous drainage. This is the mechanism, like how it acts, how the laser acts. These two, if the patient is non-compliant with the medical therapy, or even with the maximal combination therapy, that is even 3 drugs are used, but still if the patient is not having the good IOP control, then we can move on to surgical therapy. Okay, so the uncontrolled glaucoma despite maximal medical therapy and the trabeculoplasty, we prefer surgical therapy. In a non-compliant patient also, we prefer surgical therapy. And then the eyes with advanced diseases, okay, we can directly go ahead and do surgery instead of trying and wasting time in medical therapy. Very high OP, advanced cupping and visual fields, we prefer surgical therapy. So what are the surgery which are recommended? Types of surgery are trabeculectomy. Okay, so this is the most commonest and the standard method for primary open angle glaucoma. Newer ones are there now, the like glaucoma drainage devices are available. Just to mention, if you can know that is enough. Okay, drainage devices are also available. So in trabeculectomy, what we do is there's a glaucoma filtering operation which controls the IOP by establishing a pleb. Okay, the aqueous fluid is made to enter the subconjunctival tissue. So while explaining the aqueous drainage system, I have already told you where the aqueous fluid goes. Okay, through the trabecular meshwork, it goes to Schlemm's canal, and from Schlemm's canal, it goes to episcleral veins. So this is bypassed, and then the fluid is made to enter the subconjunctival space instead, okay, and get absorbed. So thereby reducing the intraocular pressure. See, this is the picture. Sorry. See here the bleb. This is how the bleb looks like. So what we do is in the trab, we make a partial thickness opening in the sclera. So this is the scleral opening. This is the conjunctiva. Below the conjunctiva, scleral opening is done. Ostium is created here. PI is done. That is peripheral iridectomy is done in the iris, and then we ensure that aqueous humor drains through this PI, through this ostium, that sclerotomy, and then comes out through this ostium to the subconjunctival space. Okay, this is the bypass. This is the trabeculectomy. So this is how, these are the steps. Usually the steps are not asked, but just in case, okay. For undergraduates, it is not asked, but just in case, okay, we just make a nick in the conjunctiva. So this is how the conjunctival nick is made. Okay, the conjunctiva is lifted back, and then we make a, with the scalpel blade, we open up the sclera like this, partial thickness opening, like a window we make. See, this is how the window is made. So in this we make a ostium. Okay, we make a ostium. So another partial thickness. See, this is ostium. Either using a scalpel blade, we can make a opening like this, or using an instrument. There is some for to do a trabeculectomy, one instrument is there. So we can punch this. Okay. So punch is available. We can punch and make a ostium here. And then iris is taken out. We do a peripheral iridectomy here. See, iris is cut here, and then suture back the flap. This flap is placed back, and then we put a releasable suture there. Suture here, suture, and then conjunctiva is sealed with using continuous suture. So from here the aqueous is drained and it forms a bleb here. Okay, this is the procedure of trabeculectomy. See, this is a there are few, so in any surgery there are some complications. So there are some complications because of trabeculectomy, that also we have to look for. I think for undergraduates it is not required, just you remember trabeculectomy is done. So in advanced cases, even the conjunctiva cannot hold that much of IOP cannot be controlled only by doing a trabeculectomy. That time we do use a mitomycin C, which is a fibrinolytic drug, okay, to have a well-functioning bleb. And then there are some glaucoma drainage devices also, which we place underneath the conjunctiva and put a tube inside the aqueous humor. Okay, so that is not included in my slides. So just for your information, just know there are few glaucoma drainage devices also, which we placed. So there is a tube which is placed in the AC, and then device is placed underneath the conjunctiva, so which drains the aqueous humor in a very advanced glaucoma cases. Okay, so this is the whatever I have covered today is visual field defects, and then the management of primary open angle glaucoma. The medical line, surgical line, and even laser therapy has been covered. Okay, please go through that in your textbook, because this is very important topic. May not be included in your internals this time, internals, but it is very important topic for your exams. Okay, thank you for the class.